guys, welcome to another lesson in our emergency management series. Tonight, we're going to discuss increased intracranial pressure, or ICP, and specifically how to identify it in the emergency department and what to do about it. So, just because we may not have an intracranial monitor doesn't mean we can't spot an increase in ICP. Altered level of consciousness, nausea, vomiting, seizures, headaches, focal deficits, and anisocoria are just some of the signs and symptoms that we can indicate an increase in that ICP. It's really vital to know the steps to take when we see those changes. So, what's going to tell us that our patient has an increasing intracranial pressure, or ICP? There are early signs and there are late signs. Trust me, you don't want to see the late signs. So some of the early signs are headache, which really it can be like a minor headache or the worst they've had in their life. They could have some nausea and vomiting. They can suffer amnesia. And the cool thing about that, well, I don't know if it's cool for them, but it can be as simple as not remembering what happened leading up to their injury, or as serious as like forgetting their own name and where they are. They can also have behavior changes like some impaired judgment, increasing restlessness, and on the flip side, they can actually have increased drowsiness. All of this leads to kind of an alteration in level of consciousness. Now, late signs, which are bad, can be dilated non-reactive pupils, which starts as unilateral, just one-sided dilation, and then progresses to both dilated pupils. They're going to be unresponsive to verbal or painful stimuli. So, given that sternal rub is going to produce nothing, they might have some abnormal posturing and that muscular rigidity, those kind of locked muscles. And they can begin to show signs of the Cushing response, it's a combination of widening pulse pressure, bradycardia, and decreased respiration. So if you see the combination of these symptoms, it is bad. It's also known as the Cushing's triad. This is a very, very, very bad thing. It's usually a sign that their brain is herniating, and I think that goes without saying that is a true emergency. So, increased ICP comes from an insult to the brain. Now, this can be from any number of causes. The most common, of course, is head trauma. It can also be from a hemorrhage that can be a result of something like a stroke or a ruptured aneurysm. It can also be non-traumatic causes such as hydrocephalus or tumors or cerebral edema. And basically, anything that causes the space in the skull to decrease is going to cause an increase in ICP. Blood, CSF, swelling of the brain, all of that can lead to a very, very bad day for our patient. If you look at our guy over here, the white spot is hemorrhage. This kind of gray shading is all cerebral edema because of the shading. Now, the interesting thing here, and you wonder, well, where's the pressure coming from? If you look, the midline of the brain should be here. That's the midline. And if you look at the shadow, this guy's midline has kind of shifted a little bit this way. This hemorrhage is pushing everything that way. It's causing that increased intracranial pressure. Obviously, not a good day for our patient. If you guys want to learn more about intracranial pressure, like what is normal, all the ways that it can increase or decrease, and things like the Monroe-Kelly doctrine, which I'm sure you heard about in nursing school, please go check out the neuro course under our med-surg units here on nrsng.com. So, what do we do in the emergency department? Well, first and most often, we have to assess. Our first and our most common neuro assessment is the Glasgow Coma Scale, or GCS. This is the measurement of verbal response, eye-opening, and motor response. And the scale goes from 3 to 15. 15 is good, means the patient is alert and oriented. And 3 is, there's not much going on at all. Now, I've said it before and it bears repeating, guys. Technically, the computer screen you are watching this video on has a GCS of 3. So if your patient also does, you can imagine that's probably not a good thing. So we will continue to perform pupillary assessments, and we're going to be on the lookout for, new word, guys, anisocoria. Anisocoria. It's basically just a fancy medical term for this, the unequal dilated pupils. See, this one's dilated, this one is not. That is anisocoria, or unequal pupils. We also want to watch the patient's reflexes and be aware of posturing. So we look for decorticate posturing, in which the arms are kind of pitched, pulled towards the center of the body, bent at the elbows. And we also look for decerebate posturing, in which the arms are locked and the wrists are kind of turned outward like that. Both of these are bad, but decerebate posturing is usually a very, very late sign of increased ICP and can also be a sign of brain herniation. Again, we just said herniation, very bad. Be on the lookout for that, guys. So let's treat our guy. If the ICP is being caused by restlessness, anxiety, or pain, we're going to need to relax the patient and get them out of pain. So medicate them. Usually something for sedation, like Ativan, and something for pain, maybe morphine. On top of that, you might want to give an osmotic diuretic like mannitol to reduce the ICP. So if the C-spine has been cleared, please, for the love of God, guys, get that C-collar off. If you want to know how comfortable that thing is, go put one on and see how your patient feels. Also, medically, the C-collar can actually reduce venous outflow due to the pressure on the jugulars. Now, once we know the C-spine is good, we can elevate the head of the bed to about 30 degrees. And if you wonder what that looks like, that's 90. That's about 45. So about here would be 30 degrees. So there's your bed, your wheels. You want to elevate to about 30 degrees. And the reason being we don't want to go too high or too low is because either one can actually cause more pressure. Too low, and it's due to increased blood flow to the head, and too high, it's because of increase in abdominal pressure, preventing venous return. So we want to decrease stimulation as much as possible. And I know it seems crazy in the emergency department, and when we're in an acute life-saving situation, it is. But once the patient is stabilized, we want to try to move them to a quiet, dimly lit room, keep it monitored, an area where we can provide really thorough care with the minimum of irritation to the patient. So if their GCS is less than 8 and they have an abnormal CT scan, neuro might jump in here and get a little more involved. So in the ED, they can place an internal ICP monitor or perform a ventriculostomy. That's actually, drilling holes in the patient's skull. And then they'll insert an EVD or an extraventricular drain to drain out some of that building fluid. And if all of this is not enough, they got to go to the ER. They're going to have an emergency craniotomy performed where they're going to pull off a piece of the skull to allow for reduction in swelling. Actually, they allow for the swelling to occur and then not be a problem. We need to keep an eye on our patient's cognition. We do that with our serial neuroassessments, documenting our GCS. With our ICP, it's all about proper regulation, whether that's through simple means or advanced techniques like medications or surgical procedures. And we need to know what's important, guys. Do we intubate first or position them first? Do we give mannitol or morphine first? Much like many of our ED cases, prioritization is vital to their proper care. Couple of key points. We got to know the signs of increasing intracranial pressure. What's an early sign and what's a late sign? Feel free to look back over those. There are lots of possible causes. Really, that thorough history is going to help your diagnosis and your treatment. What happened to them? Trauma is obvious, but if they have some underlying cause, we need to know that. Perform those neuroassessments. Document that GCS well. Remember, 3 to 15. Keep documenting that, depending on your patient, every 5 minutes, every 15 minutes. Check with your facility's protocols. Whether we're doing something non-invasive or invasive, we have to treat them. We have to do something to help our patient. And as always, watch your patients. Continue to monitor these guys. If not, they can crash really quickly, and we need to pick up on those kind of subtle cues that are going to alert us to the downward spiral of increased intracranial pressure. Okay, guys, so that's all today about increasing intracranial pressure. Feel free to check out some of our other emergency medicine lessons throughout nrsng.com. And as always, happy nursing.